Cerramos con un enfoque, una vez más, fisiológico. La inteligencia al servicio de lo que hacemos todos los días. Y me gusta el nombre, Monitoreo hemodinámico funcional. Tenemos una vez más al doctor Pinsky, que nos va a hablar acerca de esto y su vínculo en cuanto al concepto de si esto determina la respuesta al volumen.
Thank you. And this is my last lecture of the day and actually of the meeting. So if you have any questions for me, you'll have to get me at the lunchtime. Let's see. Can I have the slides on? Okay. So functional hemodynamic monitoring. Now, I need to tell you about the conflicts of interest here because I am the owner of the inventor of a patent that the University of Pittsburgh owns, which is functional hemodynamic monitoring. And so I have a significant conflict of interest, but I'm kind of glad we have this patent so that no industry can make money off it because I'm not charging anyone for its use as long as industry doesn't make money on it either. Okay. As I said before, it's a monitoring truth that no monitoring device will improve outcome no matter how accurate it is unless it's coupled to a treatment which improves outcome. And when we think about functional hemodynamic monitoring, we have to think about it in a very complex way. There are three primary clinical problems that we're trying to address. One is to identify patients before they become too sick, because once they've had organ injury and organ failure, resuscitation doesn't work. The second is how to determine the most appropriate therapy immediately to treat that patient with so that we can reverse the shock. And the final one is how do we implement this therapy across healthcare systems in which the doctors and the treatment methods are so different across all systems that it's very difficult to do things commonly. Well, today I'm only going to talk about the middle one. How do we identify the most appropriate therapy? Well, why don't we just give volume to every single patient who comes in shock? The signs of cardiovascular insufficiency are impressive, but they're nonspecific. Hypotension will decrease the blood flow to the brain and the heart. And most forms of shock are associated with a decreased effective circulating blood volume. Well, Frederick Macar and Jean-Louis Thibault actually asked this in a meta-analysis. Why not give volume to every unstable patient as primary resuscitation? And they looked at all the studies for which people had presented in shock either to the emergency room or to the ICU or on the floor and just asked if they were volume responsive. And I'm actually an author on 3 of the papers they reviewed. And so what they did is they identified patients as being responders if they had at least a 15% increase in cardiac output and a non-responder if they weren't. And you can see for the group as a whole, approximately 50% of the patients increased cardiac output when given volume, but 50% didn't. So giving volume to a patient in shock as the initial management will be right only half the time if you don't think about what's happening with your patient. Furthermore, you will be delaying the right treatment half the time, and if they're in cor pulmonale or have pulmonary edema, you might make them a bit worse. So, fluid can be dangerous. Well, is cardiac output? That's the question we want to know when a patient comes in shock. Is the blood flow adequate to meet the metabolic needs of the patient? And if I put them on mechanical ventilation, will cardiac output fall? And if I give them fluid, will cardiac output go up? What we're asking from a physiologic perspective is my patient preload responsive? So, we assume that venous return and left ventricular preload are the primary determinants of cardiac output, and we evoke Starling's law of the heart. And we assume that if we have a low left ventricular end diastolic volume, that we're going to be volume responsive, and we measure all the surrogates we can of left ventricular end diastolic volume, CVP, pulmonary artery occlusion pressure, left ventricular end diastolic area, intrathoracic blood volume, whatever. Well, the reality is that none of these values ever predicted volume responsiveness. Neither do their changes. This is the change in CVP versus the change in stroke volume. There's no relationship. This is the change in wedge pressure to change in stroke volume. There's no relationship. There's also no relationship between direct measures of preload, left ventricular end diastolic area, in responders and non-responders in septic shock. As you can see, the overlap of the data between the two is complete. I'm not going to go through all the literature, but one of the prettiest studies was by Kumar and Joe Perillo's group, in which they took patients in shock and they gave them fluid. And as you can see, there was no relationship between right ventricular end diastolic volume or its change and CVP or its change, left ventricular end diastolic volume or its change, and wedge pressure or its change, or the effect of stroke volume. So if you learn nothing else from my lecture at all, and this except one thing, learn this. Preload is not preload responsiveness. I can have a big ventricle and be volume responsive. I can have a small ventricle and not be volume responsive. The most common form of heart failure in the world today is diastolic dysfunction. And that's heart failure with preserved ejection fraction. So don't measure pressures or volumes at any point to determine volume responsiveness. Now, I'm not trying to give you mixed signals. Starling's law of the heart lives. If you do increase volume, stroke volume will go up, but you have no idea from any given end diastolic volume or pressure that you start with if in fact that will happen. So I haven't said that physiology is wrong. I'm just saying that you can't assess it from measuring the static variables. Well, what can you do? Well, you can use heart-lung interactions. The increases and decreases in intrathoracic pressure will alter venous return. And it should be thought of as if you have two beautiful systems on top of each other, one the air and the other the blood. As I showed you before, with positive pressure breathing, as the pleural pressure rises, CVP goes up, causes right ventricular filling to go down, and right ventricular stroke volume to go down. And as I showed you before, after a couple of beats, this results in a decrease in left ventricular preload and a decrease in left ventricular stroke volume. So why don't we use stroke volume and pulse pressure variations to look at volume responsiveness? Think of it like with every breath, the amount of blood in the chest is going up and down like a whale in this sound. Okay. So to explain this a little bit better, I want to go back to a little bit of medical school physiology, and I apologize. But if we were to look at left ventricular function as a measure of left ventricular pressure and volume, as was described by Starling in 1914, you would see that at the initial opening of the mitral valve, the ventricle has very little volume and very little pressure, and it fills during diastolic filling until the heart starts to contract, the mitral valve closes, and we get isometric contraction until the pressure in the left ventricle and the aorta are equal. The aortic valve opens, and boom, we get an ejection of a stroke volume to our small insystolic volume, and then the heart relaxes. Okay, so we can look at left ventricular pressure volume loops. If you were to look, and this is in a real animal, this is the left ventricular pressure volume loops corkscrewing through time with arterial pressure superimposed. You can see how dynamically elastic the left ventricle is associated with positive pressure breathing. So whether you like it or not, with every positive pressure breath, you're going to be altering preload on the heart. And to the extent that the heart is volume responsive, you'll see a change in its output. So Young-Gu Kim from our laboratory looked at an intact dog in which we separated out the ventilatory cycle by color, and we specifically looked at the pressure volume loops that occurred at end expiration here in blue, and then the various other colors. This is end diastolic volume, and as you can see, there is a decreased preload that occurs with positive pressure breathing cyclically, and this results in a decrease in stroke volume, which is your stroke volume variation. So we can look at stroke volume variation and determine if a person's volume responsive. So let's assume I have a good heart and a not so good heart, and they're both underfilled. Then I would be ventilating the patient so that the preload would be going around in this region here, and I would see that the stroke volume variation of both hearts would be above a certain level. If I fill the hearts a bit further, the sick heart doesn't do as well and has no more stroke volume variation, but the good heart still does. Eventually, when both hearts are filled, neither one will have a stroke volume variation. So it doesn't matter where your heart is or anything. If you have stroke volume variation, you will be volume responsive. Okay. Well, I can capture that and use it because the relationship between pulse pressure and stroke volume is tight. We took a series of human beings and we cut open their chest and we put a flow probe on the aorta of human beings and we put our finger on the inferior vena cava and we decreased preload and we watched how arterial pulse pressure fell associated with aortic flow. And this is the gold standard for flow. This is real. And what we found was that over the physiologic range, there is a linear, tight correlation between pulse pressure and stroke volume, and I can measure pulse pressure in anyone. So, what it's basically doing is you're capturing the dynamic changes in pulse pressure over time. Not the mean pulse pressure, but their dynamic change. And just like this water looks like it's created something when a splash occurs, what you're looking at is that dynamic change. So in collaboration with Frédéric Macquart and Jean-Louis Thibault, when I was on my sabbatical in Paris about 15 years ago now, I guess, we looked at the relationship between, here it is, arterial pressure, and pulse pressure variation. Now, if you look at the systolic pressure variation, that's pulsus paradoxus. But it doesn't take into account at all the changes that are occurring in the diastolic pressure. If you look at the diastolic pressure to systolic, or the pulse pressure, you can see that it's going to be a better representation of stroke volume. And so if you look at the pulse pressure variation over the mean, that's the pulse pressure variation. Okay. So the first study we did was we said, in patients who have acute lung injury and ARDS, if we were to give them 10 centimeters of water PEEP, will their cardiac output fall, yes or no? And so we measured the change in cardiac output versus the baseline level of PEEP, of pulse pressure. And if you had no pulse pressure variation, there was no fall in cardiac output because you were in heart failure. The greater your level of pulse pressure variation before I added PEEP, the greater the fall in cardiac output. Then we said, okay, let's take septic shock patients. And in sepsis, where the blood pressure is low and the cardiac output could be high or low, what happens when we add volume? And we said, what was the pulse pressure variation before we gave 500 mLs of hydroxyethyl starch, which we probably shouldn't give anymore. And what we found was that there was a tight linear correlation. The greater your pulse pressure variation, look, if your pulse pressure variation is 35%, your cardiac output will go up by 35% in response to volume. Okay? And since this is a test, one can look at the receiver-operator characteristics of the test for its sensitivity and specificity. If you don't have a pulse pressure variation, you don't have volume responsiveness. Okay? Well, you don't need to just look at pulse pressure. You can look at esophageal Doppler flow. There's a device out there called USCOM. You can use that in looking at the aortic arch. You can use the pleth signal of a pleth pulse oximeter. Anything that gives you the pulse density variation over time will vary with ventilation and will give you a volume response signal. So as of about 3 weeks ago, when I did a Google Scholar search, there were over 1,910 independent publications looking at this. I know of no other test that has been shown to work so well. This was looking at pulse pressure variation, stroke volume variation, inferior vena cava collapse, superior vena cava volume changes, pleth signal variability, esophageal Doppler flows. Every study that looks at these has shown the exact same thing. As Jean-Louis Thibault showed me in this slide, mechanical ventilation decreases right ventricular filling, causing right ventricular output to fall if the right ventricle has preload reserve. So if you have right ventricular failure, you won't see a change in right ventricular output. And this occurs at inspiration because that's when the decrease in venous return occurs. As you saw, it takes about 2 to 3 heartbeats for you to get a decrease in left ventricular filling, which will cause a decrease in left ventricular output. if the left ventricle is volume responsive, and just by timing, this is going to occur at expiration. Thus, mechanical ventilation will decrease left ventricular output at expiration if both ventricles are volume responsive. I can't make it any simpler than that.
Así que utilizar este concepto de variación de volumen por pulsación comparado, López y otros estudiaron pacientes en la sala, en el quirófano, y los resultados tenían dos grupos, el grupo de tratamiento y en el cual aplicaron 3 litros de volumen de más y midieron la presión postpresión y luego la redujeron al 10%, que era su meta. Y por cualquier medida, solo haciendo esto, pudieron disminuir el tiempo en la estancia en el hospital y la ventilación, el tiempo de ventilación. Pero hay que hacerlo con cuidado porque podría haber algunos peligros que no se pueden ver aquí, pero aquí hay un búho que está aquí. Hay límites técnicos para el uso de estas variaciones PPB. Número 1, es absolutamente necesario tener una tasa fija de pulsación, de vibración del corazón. Si tienen alguna fibrilación, no lo pueden utilizar. El número 1 debe haber respiración con presión positiva porque si tienen respiración espontánea, entonces el cumplimiento diastólico del ventrículo izquierdo cambia. Sterling dice que el estrés en la pared interior aumenta. Si no aumenta ese estrés, porque aumenta el cumplimiento, no hay relación entre la variación del pulso y la respuesta del volumen. Es decir, no se puede utilizar durante la respiración espontánea. Finalmente, variaciones comparando la variación de presión con la variación de la frecuencia. Estos son los efectos del efecto de crestas cuando aumentamos este efecto de 5 a 10, de 15 a 20 miligramos por kilogramo. No hubo cambio de la respuesta al volumen, pero hubo un cambio. Si aplican esta técnica, tienen que mantener constante volumen pico. Esto es algo que mostró un estudio que publiqué en 1985 con respecto a la inspiración espontánea, que causa una disminución inmediata, un aumento en la pulsación del ventrículo izquierdo, y eso hace que haya una caída proporcional del volumen en el ventrículo izquierdo. Esto depende del ventrículo, no de su respuesta por volumen. Si aumenta la presión, vemos lo que esperamos, es decir, la disminución de la pulsación del ventrículo que no cambia durante 3 o 4 pulsaciones, pero vemos aquí que hay una interdependencia mínima. O sea, ¿qué hacer cuando tienen vitrofibrilización? Pueden hacer lo que los arqueólogos siempre han hecho durante años. Y lo que muestra este artículo, aquí tenemos un paciente que está respirando espontáneamente con fibrilación atrial, y vemos aquí un aumento en 30 de la salida sanguínea del corazón, que puede aumentar con la carga. Y de hecho, si no miden un aumento de ese flujo cardíaco, si el aumento no es más del 10%, entonces, como decíamos hace algunos años, si el paciente está respirando espontáneamente y quieren saber si tienen respuesta por volumen, sí pueden hacer un desafío por volumen o pueden hacer aplicar un método pasivo. El segundo punto es determinar si el tono arterial es normal. Sabemos que los vasoreceptores tienen un determinado efecto, pero la hipotensión no quiere decir que mi paciente no esté enfermo. ¿Cómo podemos hablar de esto? Examinando la relación entre la presión arterial de pulso arterial y el volumen de la pulsación. Si el volumen es cerca de cero, si no hay presión del pulso, si aumento mi volumen de pulso, creo una forma que se llama elastancia arterial. Y esto se refiere al tono vascular y es más representativa del tono arterial que la resistencia arterial. Supongamos que tengo un volumen determinado y una porción arterial determinada y aquí tenemos menos. Y aquí tal vez la elastancia debería ser mejor. Si el pulso es mayor, la elastancia debería ser superior. Pero esto no es fisiología, esto es física. Esto es como definimos las cosas. Utilizando este enfoque, podemos decir que si registramos un aumento de la presión del pulso, esto corresponde a esta es la respuesta del ejercicio, de la carga por volumen o de catecolaminas. Si disminuimos esto, tenemos hemorragias, choque, obstrucciones, falla cardíaca. Si aumenta mi presión de pulso, pero cambia mi presión, esto quiere decir que es algo que hay algo que está aumentando si aumenta la presión del pulso, tenemos el efecto de vasodilatador, que lo que vemos en el paciente séptico, lo que vemos en la unidad de cuidado intensivo con sus pacientes. Si no tienen el pulso, tienen que ver cómo va cambiando este paradigma y estos datos. Mirándolo simplemente, Menas-Heidian, un miembro de nuestro grupo, se preguntó si administramos a una serie de pacientes un vasodilatador que han tenido cirugía postcardíaca. ¿Qué va a ocurrir con su tasa de pulso? Si administran un vasodilatador, aumentan la respuesta y también aumenta la variación del pulso. Pero si ven lo que ocurría antes, había un valor de 1.4, 1.9 y después cayó a 1.03. Así que simplemente examinarlo la relación dinámica del punto de pulso, se puede ver lo que ocurre viendo esta presión independiente en los pacientes que tenían respuesta por volumen con una respuesta mayor del 12%, que también tienen hipotensión. Si les administro fluido y aumenta el ritmo cardíaco, también aumenta la presión sanguínea. En cada paciente que administro volumen, también aumentó el ritmo cardíaco. Pero en algunos pacientes no tenían respuesta, seguían con hipotensión, y en algunos había respuesta. Como ustedes pueden ver aquí, no hubo diferencia en cuanto a su presión mínimo arterial o su resistencia sistémica. La única diferencia fue el volumen, el valor de 0.9. Lo que el hallazgo fue que con colestencia dinámica menor de 0.9, básicamente lo que ha ocurrido es han vasodilatado y la presión sanguínea va a aumentar. Una de las maneras de ver esta respuesta, yo supongo que todos ustedes presentes tienen respuesta al volumen. Espero que nadie esté en choque. Solo porque tienen respuesta al volumen no significa que necesitan fluidos. La manera de alterar el volumen también es importante y la proporción representa el tono. Y si en la actualidad hay una serie de dispositivos disponibles en las clínicas que se pueden utilizar, tal vez sean demasiados para contarlos, pero estoy seguro que tienen por lo menos uno de estos en su hospital actualmente. Y el valor mágico umbral es el cambio del volumen de pulso después del pulso cuando aumenta más de 10. Así que vamos a dar un pequeño viaje y va a ver a las implicaciones clínicas. Pueden identificar al paciente que está enfermo críticamente y vemos, si estoy ahí en el mundo real con un paciente que tiene un colapso enfrente de mí, con choque séptico, que tiene hipotensión, ¿qué hago? Lo que proponemos es aplicar el siguiente protocolo que se está utilizando en diferentes centros. La primera Primera pregunta, ¿tiene estabilidad hemodinámica el paciente? Esta es una pregunta difícil de responder, pero digamos que obtener la pregunta sí o no. Sí.
If they're not, then we ask, are they
no hay nada que hacer.
preload
Si es no,
responsive? A pulse
entonces
pressure
hay
or
que ver
stroke volume
si es
variation, or
respuesta
a
a
change in
precarga. Si
cardiac
el
output
paciente
with passive leg
presenta,
raising
si
of
la
at least 10%.
salida del
The
flujo
answer
cardíaco
is yes or no.
es,
Remember, half the patients will be
aumenta
yes,
o no,
and half the
y la
patients will
respuesta
be
es
no.
sí o
But we
no. La
don't
medida
stop
de los
there.
pacientes
We say, is my patient
responderán con sí,
hypotensive
para los
and
otros
have
no.
decreased
Si el paciente
vasomotor
tiene
tone?
hipotensión, entonces
The
tiene
answer
que
is yes or no.
aumentarse el
So
tono
let's go through. Is my patient okay? Yes,
vasomotor.
fine. Next. Is my patient
Mi
okay?
paciente
No.
está,
Oh,
mi
does
paciente
he
está
have
bien,
volume
no.
response?
Tiene
Yes,
respuesta a
that's half my
volumen,
patients.
sí.
Okay.
Entonces
He's volume
la mitad de mis
responsive.
pacientes tienen
Is he
respuesta a
hypotensive
volumen,
with
tiene
decreased
hipotensión
vasomotor tone?
con
Yes. When I
tono
give him volume,
vasomotor
cardiac
reducido.
output
Si
will go
le
up, but
doy
blood pressure won't.
volumen,
And remember,
entonces
blood pressure is
la
the primary
presión
thing you start with.
arterial es
That
lo primero
patient
con que
needs
se
volume
comienza.
plus
El paciente
vasopressor at the
necesita
same time, and my
vasopresores
vasopressor
y
is
necesita
norepinephrine.
volumen. Y
But if
el que
they're
utilizo es
volume responsive, and they may be hypotensive, but they have normal vasomotor tone, all they need is volume.
Y
Their
con el
blood
tono
pressure will go
vasomotor
up as
todo
the
lo que
cardiac
necesita es
output goes
volumen.
up.
Aquí sube el
But
gasto
let's look at the
cardíaco,
other side.
así que analicemos
They
el
are
otro aspecto.
not volume responsive.
Vemos que
Well,
no
do they have hypotension
no
and
están
decreased
respondiendo al
vasomotor
volumen,
tone?
entonces van a
If
tener
they do have
vasoconstricción
hypotension
y
with
menor
decreased
volumen.
vasomotor tone,
Si
they need just a
existe
vasopressor. Who
hipertensión
would that
y
be?
un
That
menor
would be a person
tono
in septic
vasomotor,
shock who you
se
fluid
trataría de una
resuscitated
persona
and
con
they stay
choque
hypotensive.
séptico que
That was
tenemos
the
que
example I
reanimar
gave
y
you
va a
earlier
seguir
today.
hipotenso.
But
Es el ejemplo que
if
ya
they're
les había
hemodynamically
comentado.
unstable,
Pero si
they're
tienen
not volume
estabilidad
responsive, they may be
hemodinámica,
hypotensive, but
quizá
they don't have
estén
decreased vasomotor
hipotensos,
tone.
pero no
The
tengan
problem
menor
is
tono
between my
vasomotor.
two
El
hands.
problema sería el
It's
que se
right here.
encuentra
I
entre
don't
mis
know what
dos
the
manos.
problem is, but
Aquí
it's right
justamente,
here.
no sé cuál es el
And we would
problema, pero
start
aquí
an
está.
inotrope while
Y
we're
vamos a
looking for the
empezar
echo
con el
machine to figure
inótropo y
out what's
vamos a
happening
empezar
to
a
the heart.
utilizar los
And you
dispositivos que
could
nos
then recycle
permitan
this as fast as
ver
you want.
cómo está funcionando el corazón.
So,
Aquí es la
the
revaloración
applications
del
of functional
paciente.
hemodynamic monitoring, we're doing a
Aplicaciones de
prospective
monitoreo
study in the
hemodinámico
operating room
funcional.
of
Estamos haciendo un
goal-directed
estudio
therapy
retrospectivo
based
en
on
el
functional
quirófano
hemodynamic monitoring.
con terapia dirigida
We
a
have an approved
metas
study
y
with the
tenemos un
European
estudio
Intensive Care
aprobado
Society, which is going
con la
nowhere
European
because of
Intensive
lack of
Care
funding. So
Society
now
que no
we've
va a
broken it
ningún
into
lado porque no hay,
individual
fondos
countries.
suficientes. España está haciendo un sepsis 1, Portugal uno de choque séptico en la sala de urgencias e Inglaterra otro en la UCI. Y vamos a hacer estudios con un solo centro porque la verdad no tenemos dinero suficiente. Hemos propuesto también a la red ARS que se utilice esto para estandarizar la terapia de líquidos y así prevenir la varianza o variabilidad entre los centros. Así podemos estandarizar la atención. También lo estamos utilizando controlando las hemorragias o a través de hemodiálisis. La hemodiálisis es hacer que el paciente tenga un rellenado vascular en los espacios intersticiales y que se ponga un poco hipovolémico, pero no demasiado. Se sigue la frecuencia del pulso, le damos más libertad de movimiento y en 2 estudios lo estamos proponiendo así. También algunas compañías que se dedican a fabricar dispositivos para diálisis nos están ayudando. Por último, hay otro estudio para quienes tienen muerte cerebral y que son candidatos a trasplante de órganos. Se ha podido estabilizarlos y por lo menos duplicar el número de órganos de los que se puede cosechar utilizando este algoritmo de monitoreo de líquidos para estabilizarlos. Así que el potencial es muy bueno y otra ventaja es que es muy sencillo. Y con esto quisiera agradecerles su atención y si hay alguna pregunta, con gusto trato de responder.